this is Carol from COXO. Today is COXO 15 times COXO fee public webinar. Welcome to all the dentists from all over the world. I hope every dentist can leave the comment in our comment line, and you can win COXO gifts, the handpiece. First, let me show my screen to show you about the handpiece. For this time, we will pick up one lucky person to get the handpiece. Let me show you this one. The high-speed handpiece. COXO have a very long time history to make the high-speed handpiece, and our handpiece is very durable for use. Some of our handpiece has 1 year warranty. So every dentist, please leave your comment. Later, we will pick up one lucky person to support our handpiece as gift for you. And today we invite Dr. Latifa from Tunisia. If any dentist from Tunisia, please say hello and leave your country in our comment. Hello, I'm from Tunisia, or hello from India, such as this word. We can know where are you from. This 55 fee COXO Global Fee Public Service webinar, we invite Dr. Latifa from Tunisia. Today, his topic is treatment of uncommon large periapical lesion of endodontic origin. If any dentist from Tunisia and want to buy COXO product, please connect with our local dealer, Medical Sets. And Medical Set, Tunisia is going to have exhibition on June at the beginning of June. So our dealer also have the promotion for our microscope. Buy microscope get the 6-month mini AP. Also have the implant module. Our dealer in Tunisia, they have all kinds of COXO products, such as this low-speed handpiece, implant module, and all the range for the endo, like this one. Endo treatment one-stop solution. He have dental electrical module, endo module, file operation system, queuing line, and so on. If any dentist from Tunisia want to buy COXO product, please connect Medical Sets telephone 216. You can see on our screen 216-989-262-958. If you want buy any COXO product in Tunisia, please connect with our local dealer. And also they have the promotion during the June exhibition. If you want to testing or try of the COXO products, please connect with them. Okay, now let me tell to the dentist, all the dentist friends, how to get the certificate. All the dentist join in this webinar, we will support the certificate for you. First, you must follow our page and like as your page. And second, you need to leave your comment or question below the live video. After this webinar, we will pick up one best question. Dr. Latifa will pick up one best question to support COXO gift for you. So end of the live show, we will show you the form. We will show you the link to the common live, and also you can fill out this link and apply the certificate. About 3 steps are: 5 days later, you will receive the form, the certificate in your email. And you must be noticed, there's two notice. One is the application form is only available for one time. So, and also only available for 5 hours after the lecture. So please, if you want to get this certificate, if you think this topic is very interesting and you want to get the certificate for this webinar, you need to apply this applicant form as soon as possible. And the form cannot be modified, so please be sure all the information you left are correct. Okay, you can see here is the certificate sample. It have the stamp from 58th COXO. Also have our CEO signature. Also have the speaker, Dr. Latifa signature. And it also have the lecture, the subject of this, the subject of the in the certificate. Okay, that's all for how to get the certificate. So please follow our page and follow this webinar to get the certificate. Also win the COXO gift. And also, if you want to buy any COXO product from Tunisia, please connect with our local dealer. They have all range of COXO product. Okay, now let me introduce Dr. Latifa.
Hello, Carol. How are you?
Hello, Dr. Latifa.
Hello, everybody.
Hello.
Yeah.
Nice
Hope
to
you're
see
fine.
you again. This is our second time cooperation for the webinar.
Yeah, all live.
Okay, now I will give you the time for you.
Okay. If you wanna, at the same time, I will share my screen. Okay, and I'll present myself.
Okay. Okay.
So here we go. I hope you're doing okay. So, yeah, this is the full screen. Okay. So I'm Dr. Latifa Berrezouga. I'm professor in microbiology immunology. I'm a dentist, of course. I'm a professor in microbiology immunology, and I'm a practitioner in endodontics in the department of endodontics of the dental clinic of the University of Monastir, Tunisia, of course. So I just present myself for saying that I'm also the secretary of the Africa Middle East region of the International Center for Dental Research. I'm the civil member of the IADR, and I'm also the gold member of the Excellence in Endodontics, introduced by Professor and founded by Professor Dr. Ahmed Madarati. I'm also a member of the International Center for Dental Traumatology, and I have been invited to join the project to develop a core outcome set for dental antibiotic stewardship with the director, Dr. Wendy Thompson from FGI and UK. So this is my brief introduction as I invite you to Tunisia to visit so many nice places, a wonderful town. So I'm waiting for you. Today my talk is about treatment of unusual large periapical lesion of endodontic origin. And just to check, is everything okay with the sound and the figure? Yeah? Can I have a confirmation? Hello. So my today's talk is about treatment of unusual large periapical lesion of endodontic origin, of course. So to introduce, it's not really all the time that I have the chance to get a lesion, a periapical lesion appended to the apex. It's not really frequent, but if you have the chance to get this after pulling out the tooth, we'll have this tissue Okay, this is a pathological tissue. It's not really natural tissue, because it's a tissue that developed after an invasion of the pulp, coronal part of the tooth, and the second, and after that, the pulp. And after the necrosis, this is a reactional reaction made up of cells in that case, of course, because there are so many periapical lesions. So periapical lesions or apical periodontitis, it's the same of endodontic origin, that these lesions represent a reaction of the immune system to the stimuli. And the stimuli is the decay. And the decay is, of course, made up mainly of microorganisms that invade the tooth. So there we see here the clinical view. But with a histopathological view, you can see this appendant lesion. This is an infiltrate, inflammatory infiltrate that you see here appendant to the apex. And it's made up in the majority of the photogralinoma. We will see different histological entities of this apical lesion, but here we can see several types of it's so tiny, okay, that's several types of cells, inflammatory cells. But if you have the chance also to get scanning electron microscope, you can see this lesion appendant to the apex. This is the root, this is the apex, and the lesion is appended. And this lesion is made up of fibrous tissue that cover the lesion and prevent extension, of course, of microorganisms beyond this capsula, fibrous capsula. So what we have to know about the basics of apical periodontitis, it can be asymptomatic, just with a discrete, here we see in the center incisor of a discoloration. And there's no symptoms, just a discoloration. And it should alert the clinician to make further investigations. This discoloration could be more pronounced, it involves all the crown and even a discoloration of the mucosa, what you see here in the gingiva. But once the lesion is symptomatic, you will see different figures. Here, for example, you have a swelling with related to this traumatized fracture coronal tooth, which was colonized, of course, by bacteria, and we have this. And when we see this swelling, we can guess it's a swelling with a pus, because we can see nearly through the mucosa something yellowish. And here in an open tooth, you have the swelling, and do not let tooth open, of course, and you have just to make a simple, very little incision and drainage. But in chronic situations, and the tooth is open, of course, in chronic situation, you can have a different reaction of the immune system. And what you see here are two draining fistula. Okay, so we have several clinical aspects, but also these benign aspects could have a severe component. Here, for example, an extension of the inflammation for this patient with the cellulitis, which involve the inferior labial, mandibular lip. And patients could have also inflammation of the masticular muscles, and you have the reduced here of the opening mouth. But it could be more severe than that, with a severe trismus and diffuse cellulitis, and mainly when it associates a comorbidity in patients, especially with uncontrolled diabetes. And you can even have a life-threatening extension and even the death of the patient. So it could be very, very severe. So if we think about the origin of the apical periodontitis, the most origin and the most frequent origin is, of course, dental caries. This is a loss of substance of the coronal part, and you will have all the microorganisms and food debris and saliva through this opening window to colonize, in fact, on the crown and the roots and the endodontic system, and to lead, in fact, to this inflammation. But you will see that microorganisms have the ability to colonize even the periapical region and also the periradicular space. So as they are so microscopic, they have the ability to, in fact, invade all the endodontic system and then the periodicular lesion. When you see, in fact, you will note that there are different types of lesions. Those are not well defined. This lesion is well defined. This lesion is large, and you will see what we call a large lesion. Is it a lesion of 1 centimeter or 10 millimeters, or lesions beyond 15 millimeters? It depends on the definition, in fact, you will see. And you have to notice in the retinal radiograph not only the resolution, but also the degree of the resolution. This lesion is very resolution with a resorption of the apex here, and it denotes a chronic inflammation that lead to an important amount of bone resorption. This is not the case here. The resolution is important here, but we see somehow radio-opaque bone, so it's not really a very resorbed alveolar bone. We come to also the origin of the periodontal origin. So just to for the summary, the major etiology is dental caries and also dental trauma. And then you have a periodontal origin with this important bone loss. And this important bone loss, if without treatment, you will have even the resorption of the tooth. Okay. And after that, we have what we call a iatrogenic cause, because here, as you see, the pus is perforating the radicular part of the root, and you have this lesion in the furcal region. So this is what we call a iatrogenic origin. But if you see here in the radiograph, you cannot really guess if it's a fracture or not, because it's not really well seen. When it's a crack, we will see a crack easily, by an operative microscope, and also clinically, directly in the crown, you can observe directly. But even with CBCT, it's not really visible. The crack cannot be visible unless you will have a fracture of the tooth, so it should be visible. But hey, probably it could be a crack because maybe of this G-shaped lesion, but it's not really a systematic way of thinking that every time you have that type of lesion, you have a crack. It's not true at 100%, but it could direct us towards a crack. So a periapical lesion has been, in fact, classified into several stages by Dag or Stavik in 1986, from the stage 1 to the stages 3, 4, and 5 with a periapical, well-established periapical lesion. And of course, where these steps 4 and 5 will have the established bone resorption and extension of the lesion. But with CBCT, you have a 3-dimensional view of this lesion, and you can appreciate more the extension of the periapical lesion. And this is the classification of Estrella in 2080. This is a work done by one of the now she is graded for her for dentistry, Sumaya Nazi, and the director is one of my students and my colleague now, Associate Professor Rim Mabrouk. This is the thesis about the accuracy of CBCT versus panoramic radiographs. And as you see here, it's more accurate to see different steps and stages of the lesion used on CBCT, and with advanced stages, this extension with resorption of the cortical bone. So the accuracy is significantly higher with CBCT compared to even retroalveolar or panoramic radiographs. Here, the study was concerned, in fact, panoramic radiographs. So there are also criteria for what we call healing of the lesion. So healing of the lesion, in fact, is a distraction of the tissue, the tissue of the periapical region or the periradicular region, and that also could involve the tooth or the apex of the root. So you will have even distraction of the cementum of the dentin. And this is a complex region that healing, it depends on the extension and the level of distraction, both on the alveolar level and also on the tooth level. Healing will be as a regenerative therapy after, of course, adequate root canal treatment. So we speak about healed lesion, that to say that we have complete regeneration of the lesion. As you see here, this is a periapical lesion, resorption of the apex here, this periapical lesion. And after disinfection and root canal filling, you have a complete healing. This is, of course, a retroalveolar radiograph. It's not also a systematic way to perform CBCT, even if CBCT, you will see, has a lot of indications. And here, what we call is the healing lesion. That's to say, it remains a bit of regulation. See here, I have to follow the patient, even if we may be sure really that it will be a healed lesion, but we never we get never to be so sure, because you can have this lesion and follow your patients, and after that the lesion reappears. So and probably there are so many explanations for that, and what we call the diseased. The tooth is diseased, that is to say, you cannot have this healing in this situation. So if we perform root canal treatments after, of course, instrumentation and disinfections, which are really the most important steps in root canal treatment, is to avoid the appearance of a lesion, or to have at least the regeneration and the healing of the lesion. So if you have root canal filling, try to follow your patients, even by phone. You can have by phone at least information regarding the absence of symptoms, etc. And you can invite your patient just for a retroalveolar radiograph and a clinical check. So the periapical lesion is really a disease. It is mostly due to microorganisms, but they have to take into consideration several factors. Owing to the host, we can never have the same reaction, to the stimuli. So we have an individual immune system, even if we can answer similarly to some kind of therapeutics, but we have different reactions. And the disease, as apical periodontitis, is diverse. We have no one apical periodontitis. We have several histological types, which is seen by works of Sikera and Ricucci. You have at least abscess, you have cyst, and you have granuloma. And at least these three types, but you will see that within the cyst, you have different types of cysts, and if the granuloma will develop to cyst, and if the granuloma will develop to the abscess, and if the cyst will be reinfected and will be an infected cyst, but you will lose, in fact, all the periapical tissues, and you have find just pus and probably the membrane of the cyst. We cannot really speak about granuloma or cyst clinically. It's not possible. We have to do what we call histopathological investigation. So it's one of my publications about apical periodontitis with a high incidence prevalence, because I found, I think, a percentage of 46% of apical periodontitis in patients I have treated. So I have said, as I have said previously, if we consider this lesion a large lesion, it depends on the terminology and definition of a large lesion. For me, it's quite large. It's not really a small lesion of 0.5 millimeter. Nearly to 20 millimeter. And you have, this is very important. I didn't insert here the clinical photos, just the radios, but there's a history of trauma with a discoloration of the incisor, which is very important in the lesion, that you have to notice the number of teeth involved in the lesion. And it's very crucial to make the difference between vital teeth and necrosic teeth. And vital teeth, clinically, you can appreciate, of course, the discoloration of the tooth. When you have a vital tooth, generally it's not discolorated. If you have, I speak about, for example, white teeth, because with tooth and teeth discolorations, it's not really obvious to identify or investigate the additional discoloration due to coronal part necrosis. But this is really important that clinically you can make your diagnosis, and radiographically you have to know at least the number of teeth involved in the lesion, and you have to treat the necrosic teeth because you have performed vitality testing, and this incisor is involved but is not necrosed. This is very important after 2 years, and we have this regeneration, in fact, of your tissue. This is a natural regeneration, of course. This is also a quite important lesion with the context of a trauma to the central incisor. And it's not really common to see that type of lesions in the palatal side, and you have really to make a diagnosis with this traumatized incisor. So when you open, you will have this drainage. As we have an immature apex here, it's really, I think, easier to have an important drainage, with pus, and then mix it with blood, because in the lesion which is infected, you will have liquid, which is made up of cells, of blood, of pus, etc. So once you have made your drainage, at that time I have thought about the bleeding technique, and I made this bleeding technique, and you see here in the one session you have this in fact swelling after drainage. And of course, under operator microscope, you can after that, after disinfection, fill your root canal with MTA here. But when I did the bleeding technique, when I insert this file, I have been stopped, here. And I say to myself, certainly, I put calcium hydroxide, okay? And there's something here happened, and what I call the tissue apical plug. I have cells, when you made the bleeding technique, you have cells, and after that, this tissue could calcify, and I started my obturation with MTA at this It's very important at this level. It's very important to follow after that with the CBCT. If the patient has nails to do CBCT, to perform CBCT, and you can follow for a couple of years, such type of lesions. And you will see after that, in fact, the different point of views of someone who is performing endodontics with quite large lesions and the oral surgeons, And it's not really a systematic also question to say that I have a quite large and even smaller lesion to perform systematically a periapical surgery. You have symptoms, you have the radiograph, you have the patient, and you have to combine different clinical aspects and radiological aspects and decide if you have to go for the surgery or not. And it's not really a question of a large lesion and a small lesion, and that a large lesion needs a surgical intervention, and a small lesion could be treated by conventional endodontic. It's not really true, because histopathology shows you the opposite of this reasoning. You can have a small lesion and a persistent small lesion that cannot heal despite your adequate root canal treatment. So this is also a work I have done with one of my ex-graduated dentist, 𝐄𝐧𝐠𝐥𝐢𝐬𝐡, about lesions, pathological lesions removed by surgery. And we find out of 14 lesions, I think out of 100, more than 100 endodontic treatments, inflammatory granuloма or epithelialized inflammatory granuloma, foreign body granuloma, cysts, actinomycosis, and even osteotitis. We're not really focused on the types of histological lesions. It will be probably for another opportunity to speak about histological entities and to try to understand what is happening biologically after necrosis, to find that different types of lesions from the point of view of histopathology. What I show you here, this is, for example, a periapical actinomycosis. And histopathology is crucial that because you have to identify this actinomycotic lesions that are made up of cells, of debris, of microorganisms, what we call actinomycetes, that are gram-positive microorganisms. Here you have this granular and surrounded by this inflammatory reaction. So it will be great that later on I will speak deeply about what is happening concerning the histopathological and the clinical aspects of periapical lesions. But here I will show you large lesions, a large lesion that involve several teeth. But when you take a retroalveolar radiograph and the lesion is extending beyond the limit of your retroalveolar radiograph, you have at least to think about a panoramic radiograph. At that time in 2005, CBCT was not available in Tunisia, so prescribed a panoramic radiograph. And you see the lesion here is a very large lesion involving several teeth. And with a cortical bone thickening, there are indices. We can have radiological indices that probably could guide the clinician to a cystic lesion, for example. But you have to also refer to expert in oral radiology, and I'm working especially with my colleague and friend, Professor Tuhami Ben Alaya. And So what we did, what I have done at that time, that the patient was with complaint of an abscess, a very painful abscess. And she was already scheduled by the oral surgeon for the surgery. And the oral surgeon was asking for the root canal treatment of teeth. Well, of teeth, yeah, okay, but what kind of teeth? Do you want me to treat all these teeth or just to identify necrosed teeth and treat them? And also, there's a big topic regarding treating or performing root canal treatment with large periapical lesion in vitro and even in necrosed teeth. So I don't know, there are so many ideas about that topic. So what I have done, in fact, it's not really easy to open teeth because the patient is suffering also from a hyposensitivity because of the importance of the lesion. And when what I did first, when you have a lesion and a great pressure into the lesion, and it's very painful, try to make a small incision for decompression first, okay? And after you can make your cavity access, okay? So I have 3 necrosed incisors, and I'm not really sure, probably severe or pulp, but the patient is uh, did not really feel any pain because probably of this hyposensitivity. So as you see here, this is a liquid, a cystic liquid mixed with pus, and it can guide us for a cystic lesion. When you see, this is very important, not only to investigate the number of teeth involved in the tooth, but to interpret very well and with caution the radiograph. They see the enlarged distance here, a decrease of the distance between the 2 incisors here. And after root canal treatment, disinfection, of course, root canal treatment, you will no longer see this distance between, as if teeth are floated in the lesion, because they're no longer available to sustain the roots. And after that, you have the building, the rebuilding. That's to say, the regeneration, the natural regeneration of your bone. And when you send the biopsy to the histopathological physician, my colleague and also my colleague, Professor Badruddin Sriha, with whom I have done a lot of biopsies and a lot of histological analysis. And you see, this is epithelium, and underneath we have the connective tissue, the inflammatory connective tissue. And you can, of course, identify this epithelium and this connective inflammatory tissue, and you can identify some, what you call, some giant cells. That's to say that you have all these cells that you see here are immune cells, okay? And these particular giant cells are macrophages, that coalescent macrophages with several nuclei here. And these are the most, I think, the most powerful immune cells, okay, with polynuclear and macrophages. This is really a kind of war, in the periapical region. But you have to remove surgically this lesion. It's not really to treat with conservative only root canal treatment. I got really, in 2022, the chance to meet again my patients after 70 years. And I got the idea because I said to myself, if the patient has the same phone number, and I said to myself, I have just to see if she kept the same phone number, and I called her, and she kept the same number. This is really great. After 70 years, yeah, I've asked her for a CBCT. Everything was okay. And what you see here in the CBCT, the healing after 70 years, well, different views of the CBCT. And what you see here, the incisors and no recurrences or no symptoms, and everything is okay. So if you have the really opportunity to follow your patients, and if you have the opportunity that they keep their phone numbers, you are really lucky. This is really amazing, because until now I'm thinking about what happened. This is a lesion that I have seen in the hospital of Fatuma Bourguiba with my colleague and oral surgeon, Professor Mohammed Ben Khalifa. And the patient just complains about a mild pain on biting. And you see here the scroll. And it was really, we have discovered the lesion. We are not waiting to find that type of lesion at all. And that's why we have asked for a CBCT. But when you make there's nothing, no swelling, no intense pain, no sharp pain, nothing. So when you see here on this panoramic view, you see that there is a redolution here, and probably there's something like a past here, very radiopaque. And this is the redolution, see, that something lateral, okay, in the region of the furcation. And there's something here as a tunnel, and you have this great lesion. Oh my God, what's that? It could be probably two lesions. The one related to this tooth 7 and another one, maybe, and there is a connection between the two, but I have no explanation for that. Isn't it? I don't know. So what we did is that we made several slices of this CBCT, and in fact, to appreciate the extension of the lesion, of course, the 3-dimension and this relation with the alveolar nerve. And when we decide to make the surgery, of course, by my colleague oral surgeon, Professor Ben Khalifa, we found this first sign, the resorption, the coronal resorption with a tissue here. And this tissue was resistant. We cannot even remove it. And we understand that this tissue is in connection with the tissue in the large lesion. I make you notice that in the tooth, the tooth 7 here, the second molar, mandibular molar, test vitality was positive, okay? So we have not attached to the tooth. And after that, okay, so my colleague has filled the lesion with PRF, and after that, I have to investigate the reason why there's a delucency related to the furcal region, and with a continuous lesion to this great lesion that we have seen. And you see this type of tissue that resembles, or maybe to a cyst, a membrane cyst. And I have removed all this tissue, was sent to the laboratory histology for histological investigations. And when I removed this tissue, I found this perforation. So this perforation, in fact, there's a past with a perforation. And this perforation lead with the time, I don't know, according to the patient, this is a very old treatment, and which is not really symptomatic. And we have really to ask why these unusual lesion and the chronic lesion by the time that did not really reflect symptomatology, the symptoms of the patients, the mild symptoms and very big lesion. And the histology confirmed, in fact, the periapical nature of the cyst. Okay, so we are more than sure that this is an apical endodontic lesion. And of course, we also working with our colleague, Professor Tuhem Ben Ali, because we need to understand very well extension, etc., the type of lesion, the limits of the lesion before removing the lesion surgically. We have to pay attention that we are sure that there's an endodontic origin. And this is 1 year recall, and the patient is here and well. And she is scheduled for an implant, of course, a dental implant. And this is the last case that I have seen with my colleague, oral surgeon, Professor Mohammed Ben Khif, and also my colleague, Dr. Mohammed Sahbi Layuni. This patient came to the Department of Dental Medicine of Fatima Bourguiba with the chief complaining of sharp pain, a left sharp pain. So if you see on the 𝐤𝐧𝐠𝐥𝐢𝐬𝐡 level, there is really a discrete swelling, okay? But on the endobuccal level, there is nothing. But I can at least make a palpation of the cortical bone, and probably I can appreciate the extension of an intraradicular lesion, not radicular, intraosseous lesion, okay? And even on the palatal level, there is nothing to see. But if you pay attention, you have just to see the color, the natural color of teeth, okay? And this tooth is discolored. It is a whitish tooth. And you have to take photos of the teeth. It's very important to compare with the antagonist teeth, etc. And when you took a photo of these two lateral incisors, the first thing to appreciate is the marked morphology of the sangula, okay? Both in these teeth, but this one is discolored. So you may appreciate more with magnification, of course. And when you see that, well, something like groove here, something like a groove, you can maybe think about dental anomaly, what we call dens invaginatus. This is really rare to see a dens invaginatus implicated in such a lesion. It's a very important lesion, nearly 40 millimeter, 4 centimeters. And you have several teeth involved. And you see here, in fact, this is really very important if with a radiography can diagnose dens invaginatus. But it's more accurate when you took a CBCT. You will see here an enamel-like tissue on the palatal side, okay? And this radiolucency is the main canal, okay? And this is really something like a groove here. And even in the lateral, in the other lateral, on the other side tooth, and you appreciate the volume of the lesion. And you see, this is the dens invaginatus. It's not really extended to the radicular part. It's just at the level of the segmental junction here, what we call there are several types, and now I will have my conference with Professor Ahmed Madarati regarding dens invaginatus. And which is very important here also to notice this curvature of the lateral incisor on the lingual part. And I have to precurve, of course, your file when you enter with the file to investigate the canal. So the pain was so sharp. I began to do my cavity exit, but it was so painful. So I proposed to the patient to make an incision and to make what we call a decompression. And I review the patient tomorrow after not 24 hours really, but after a couple of hours at morning. And I do my cavity access with no anesthesia, with no pain. And what you see here is really sufficient from this small opening of the main canal to have all these paths. This is the envisionation, okay? This is the palatal view. This is the envisionation. And you see here this enamel tissue like with the dentin here. And in fact, it's an unfolding of the enamel and the dentin. And this type of anomaly is in connection with the main canal. That's why you have a necrosis. And ask yourself, why all this time? Because it's so tiny. The invagination is so tiny, and it took a lot of time, for the tooth to be necrosed with no symptoms at all. But the patient had symptoms once the lesion gets infected. I have to know that microorganisms are the origin of pus, and infection can lead to symptoms. And the patient is completely relieved from the pain and from this great pressure, and the endodontic treatment was performed. And here, after 6 months, you see the healing. The process of healing, of course, not really the complete healing after 6 months. It will take at least probably 3-4 years for complete healing, maybe after 5 years, I don't know. And I'm in contact by phone with this patient, and everything is okay. And I'm waiting for the visit after more than 1 year, I think, to take a new CBCT and follow by phone. So that's all for what we call relatively large lesion and large lesions that require surgical intervention and histopathological analysis. This is very important to confirm the diagnosis of benign lesions. Granuloma and cysts are benign lesions, inflammatory lesions. This is very important. And what we call large lesions, and frankly, unexpectedly, with no surgical removal of the lesion. This is really great for the patient. So I will have 1 week after what we call les entretiens odontologiques de monastère. It will be in Tunisia. And I will speak about one of my topics about management of traumatic dental injuries. And after that, in July, I have my meeting generally in Chengdu, in China, but it will be a virtual meeting with IADR. But also, we will have a virtual meeting with the Excellence in Endodontic group. And in this meeting, I will speak largely about dens invaginatus and the way to manage dental anomalies. This is my paintings and my drawings, and this is what I love to see making sport and run for human and humanitarian causes. And I would like to pay tribute to my run club of Monastir in Tunisia. Hello. And that's it. Thank you very much. You can join me by mail or Facebook, or look at my works in ResearchGate. And if you have any questions, thank you very much. Bye-bye.
Many thanks, Dr. Latifa, very excellent lectures. Now we will, I saw some of the dentists leave their question on our comment. Now let me put up some comment, and please, Dr. Latifa answer the question. Could you see the screen? Could you see the screen clear?
Yeah, I will take just I have to drink some water.
Okay.
Sorry. Yeah, Carol, yeah. Yeah. Do you want me to I will see questions.
You see it by your cell phone, right? See it by your
Yeah,
own
yeah,
cell
yeah.
phone.
Yeah,
Okay, okay,
I see on my phone. Okay.
okay.
So I try to answer.
We get a
Yeah,
lot of
yeah. Dr. Bashar asking about kind of preparation at the 0.5 millimeter in case of large apical lesions. It depends. In fact, in case of a large apical lesion, was the last measure of rotary fight to use in preparation. It depends on the lesion, Bashar. You have seen already. I have presented lesions with closed apex and lesions with open apex. And with open apex, you don't need really, you can go beyond the lesion, because your lesion could be circumscribed by a rigid capsula, okay? And sometimes when you go beyond, you will perforate this capsula and you will have your pus. If you have a continuum between the lesion and the apical part, of course. But if you have an isolated lesion, I spoke about what we call extraradicular lesions and persistent lesions. That means that even if you do an adequate root canal, your lesion is independent of what you have done with irrigation and etc. You cannot really stimulate the periapical system to enhance the regeneration of the tissue, okay? And your lesion is evaluation by her own self. That's why you have to go and remove this lesion surgically. Or you call lesions what the truth is, and which are not really in communication with the apical part. But extending beyond the apex when we have large lesion is not a problem, because we have a tissue which is infected, and mainly when you have a sort of infection with a pus, it will allow a drainage, and you have not really to. It depends. Here, I have to extend, for example, even if you have not to extend, in the last case, for example, just I have opened the tiny aperture of the main canal, and I didn't insert the file beyond the apex, and you have the depression. The lesion is so there's a great depression inside, made up of this liquid, infected liquid, that when you open, you will have this pus coming out directly. Even if you have an abscess with a molar, just you open the pulp chamber and this is a physical, in fact, drainage, the great pressure, and once you open, this is a depression, and your pus will come directly to the crown. I hope I have answered the question, which is whether to end the prep. Oh, yeah. In case of large apical lesion greater than 2 centimeters, should we go instantly for surgical procedure? I gave the tooth opportunity with endodontic treatment. Yeah, Bashar, give the tooth the opportunity. I think I give the opportunity to the tooth and the patient also. Even if the tooth is a vital organ. Yeah, I noticed that I spoke about that, of course. Yes, I spoke about this concerns regarding the surgery of apical lesion. And that's why you have to work together, or surgeon and endodontics have to work together. Because if your lesion is of endodontic origin after a part necrosis, you have to, in fact, if you have no symptoms, you can treat your lesion and you have just to follow. If you have no symptoms, and you follow your patient clinically and radiographically, you may see, of course, signs of regeneration after even 1 month, After 3 months, it could be, it depends on the lesion. It depends on the chronicity of the lesion. It depends on the synetic of the regeneration, because this synetic of the regeneration will depend on the type of cells into the lesion, okay? It's not the same way when we have an acute lesion, or we have a recurrence of a chronic lesion to an acute lesion, or we have a very old lesion that evolving since many years asymptomatically. This is what I see in the last patient. It's really enormous. And I have a lesion nearly of 4 centimeters, and the patient is complaining now about symptoms. That said, that in lesions, very big lesions of non-endodontic origin, you may discover by a panoramic radiograph very big lesions of non-endodontic origin, and even the patient is not really aware of this lesion, because all this is evolving in nearly aseptic environment. And that's why when we discover very large lesion, we have not really to go directly to surgery. We have to think about decreasing the size of the lesion, etc. So it's not a systematic behavior. You have no symptoms, you have to wait, and not to lose your patient, of course. And you have not even go through directly the lesion because you are afraid to lose the patient. You have first to speak with your patient and evaluate your patient compliance and motivation. It's very important with the clinical aspects. The patient is not really someone who is coming to the clinic and open your mouth and I will do surgery and I will do RCT. You have to evaluate the patient's motivation and compliance. This is very important, and it will influence your decision. Okay, so be careful. It's several factors will guide you in the decision to make surgery or to not to make surgery. But generally, when the patient is asymptomatic and is evolving well, radiographically and clinically, he is asymptomatic, okay? But radiographically, at least, I have not to go to surgery. If my patient is complaining with symptoms, what will be the symptoms? Or I have showed you their abscess or fistula, joint fistula, or a big abscess, big lesion. You have to perform first your root canal treatment, disinfect. You can dress the canal with calcium hydroxide. It's not really a way to treat in one step or one session. This is not the question. You have to disinfect sufficiently. And when you begin to have a resolution of your symptoms through 2-3 days, by phone, you have no longer a fistula, for example. You did a drainage for the abscess and the patient is going well. Why do you want to touch surgery, go through the surgery? But if your patient is not improving through a couple of days, all symptoms become severe, you have to think about probably it's not a lesion, and that could be healed with a conventional root canal treatment, and probably it could be an extravascular lesion, okay, that evolve independently of what you are doing in the root canal, okay. So it's not really a systematic question, and this question, the solution is within our hands, with the communication with all surgeons and endodontic and even periodontal, those who are performing periodontics. You see one of the radiograph with well-performed root canal treatment, as the patient is not treated for her periodontal disease. The resorption, of course, occurs of the alveolar bone with a resorption involving even the root of the teeth, So you will lose the teeth and more bone. So in case of large apical lesion, what's the last measure of rotary file to use in preparation? It depends. If you have open apex, even the largest one did not fit and go through the apex. If you have a small apex, I think taper 06 or even 0.4 is sufficient. It depends on the importance of the canal. Of the all obstacles of the endodontic system, here I have shown mainly lesions with related to monoradicular teeth, even if the lesion related to the molar, which is really an unusual really lesion related to the molar, but you have not really to enlarge a lot because you have a big lesion. It's not the question. And even there's also a big problem regarding the surgery and the excision of the apical part of the root, etc. So I go forward. Yeah, a lot of questions, Bashar, a lot of questions, and I have to choose one of the best questions. Um, if there is a lesion, how long should be calcium hydroxide left in the canal? Well, pulp necrosis, when you have an infected pulp necrosis, you can even without smelling this pulp necrosis, because if you are used, I'm a microbiologist also, so when I have an infection, I can imagine the smell. So we have different types of tissues, when you have a pulp necrosis, and different types of colors. And even the colors will guide you to the degree of infection. That's why there are so many investigations and research about the amount and the density of microorganisms in the pulp canal. So generally in vital pulp, we have not to put calcium hydroxide unless there's a chronic inflammation with no resorption, internal resorption. But in necrosed teeth, even if you have necrosed teeth without discoloration of the tissue, it's not brownish, it's not yellowish, you can even perform your endodontic treatment in one session. But I'm speaking about large infected lesions, but at least you have to dress your canal with at least 7 days, 10 days, and even 14 days, I think. For the patient, the last patient, it was, I think, 14 days, I think. I don't go beyond. In fact, because you have a resolution, nearly a complete resolution of symptoms, a resolution of the slight swelling, and the patient, when first he came, he has a sharp pain, he cannot sleep, he took several medications, and I just prescribed first-line antibiotic therapy, made of amoxicillin. We are not really to use even association of antibiotics. It's not really useful, and just an analgesic, a painkiller, and not really the painkillers, with codeine, just an analgesic. Because the most the most important intervention is to make this incision for decompression, and then you open the main canal, you drain all these pus, microorganisms, and cells. It will be a topic probably in the next time regarding the degree of infection and prescription, antibiotic prescription, and what we call really infected pulp with the pus or brownish pulp, etc. Because it's important to know the microbiological and the immunological side of the apical lesions. Also Bashar, I think you have asked more than 10 questions. Bashar, how long the minimum time does it take for large apical lesion to heal? And what are the factors that influence this process? This is a big topic, including clinic and immunology, the immunology of healing, it will take the necessary time, okay, depending on the host and the individual response of the host. But generally it depends on the size of the lesion. You have lesion, for example, generally, okay, 0.5 millimeter, through 3 months to 6 months. It depends on the also guidelines, European guidelines and American guidelines. We may follow to 6 months, unless you will have a small lesion, which is an extra-radicular persistent lesion. Okay, but generally, it's range between 6 months and even over 5 years. It depends on the type of the lesion, on the size of the lesion, and the histological type of the lesion, and the chronicity of the lesion. Okay, so globally, after 6 months, you can have a healing, even after 1 year. And for my cases, for example, within 2 years, 3, 4, 5 years, for large lesions, I have complete healing. Okay. Antibiotics, Bashar. Antibiotics that should a patient have enlarged apical lesions. It depends also. I will have a future. I'm working, in fact, on antibiotics project with Wendy Thompson and in collaboration with the FDI and WHO to set this way of prescribing antibiotics. Is really very complex, as this topic. But generally, we prescribe antibiotics when you have a patient is really tired, with fever, with symptoms, with general symptoms, and we can prescribe. But if you have a localized upset that you can drain easily, there's no need to prescribe antibiotics now. And there is an over prescription of antibiotics in dentistry. And you are trying to focus on this topic with the antibiotic project. What are the recommendations for the patient after we fill the canals and when he should follow up? Bashar, I think I have answered the question. When the patient is symptomatic and is coming to you with sharp pain and is really tired and ill, you have to follow him at least by phone. I have received this patient during the COVID-19 period, so the patient presents in emergency because you cannot treat him by on internet, and you cannot really prescribe by internet antibiotics. So he should come to the emergency, and you have to make this decompression by the small incision. But you have to follow the patient even at night by phone. Hey, how are you? Is everything okay? Or after or tomorrow, and say to your patient, and you have to be patient with the patient, and the patient should understand really all steps of your treatment. And if there's something risk to go bad, you have to say to your patient, call me if there's something wrong. Okay, but generally, if you did a drainage, there's no way that the situation goes worse. Will worsen. It's not the case. Generally, everything will be okay within 2 days, and you have just to see your patient after 1 week. Thank you, Prof. Ahmed Madarati, for your great comments. Thank you very much. I think we will have really the occasion, because it's the idea of Professor Ahmed Madarati to raise the awareness of our colleagues dentists regarding the accuracy of clinical and radiological interpretation of apical lesions of endodontic origin, and not to go through these diagnoses, because in some situation, and hopefully rare situation, we can misdiagnose a malignant tumor or lesion, and I have to pay really attention. That's why we have not to work by ourselves. We have to do research, clinical research, and to ask. If you don't know, you have to ask. To ask when you do CBCT, to ask a surgeon, to ask a radiologist, because everyone has his own skills. And when you ask, you have answers. So I think that with Professor Ahmed Darati, we will develop a path regarding apical lesions, the way to treat, biology of apical lesions, prescription, healing, and the biological healing, and all factors that could be influence symptoms and even healing. Okay, thank you very much, Professor. The founder, I remind you that he is the founder of the Excellence in Endodontics group, and I encourage dentists to join this group because we learn a lot from young dentists and older dentists about their experience when they pass their amazing clinical situation from all over the world, of course. I don't know if there are in every large lesion some pus coming out from canal. Yeah, I'm sorry for the pronunciation. Rajas, that's it, from India. Hello, Rajas. Um, in every large lesion. Now, take care. As I've said, you can have a lesion, a periapical lesion with an endobuccal swelling. And this endobuccal swelling is filled with pus. This lesion is filled with pus because there's a perforation or a permeation. It's not systematically a resorption of the alveolar bone, when you have the extrusion of the liquid. It could be permeability of the bone, not systematically bone resorption. And this permeability will allow the extrusion of the pus. So anyway, here the extrusion of the pus, and you can identify this pus. You can pulp and you can see just something yellowish. You are more than sure that you have to drain this swelling. But if you have not a swelling, in fact, it's like a swelling inside the maxilla of the mandible. There's nothing outside, okay, coming outside. And this is a great problem. You have to say to yourself, maybe this lesion is old and now it's symptomatic. When you have such type of lesions evolving inside the maxilla and are confined inside the maxilla and are sur-infected, it could be a granuloma with cells with no pus, and nothing will come out when you make your bad secondary infection, because bacteria has the ability to infect and to produce pus with, of course, necrotic cells, etc. You can have two options. If your lesion is in direct communication with the apex, and if the pressure is very important and your tooth is closed, once you open the tooth up, and mechanically, this is a physical phenomena, depression, and your pus come over directly, wow, what's this? Because you didn't even suspect the presence of this pus. Or you can take your file, you go beyond the apex, and you have the pus. There are several aspects, or you go beyond the apex and you have nothing. And who said that there's no pus? Because your lesion is completely surrounded by a fibrous capsule, which is very resistant to your file. But if you insist with a larger file, I think that you will perforate and have the pus. But the pus is not a systematic aspect in the lesion. You have a cellular lesion, which could be a granuloma. You have a cystic lesion with a cystic flat. But this granuloma and the cystic lesion could be secondary reinfected, okay, once bacteria achieve the lesion. I think it's clear. I hope so. Well, I don't know if there is other. Thank for the attendance. Thank you all. Yeah, thank you. I'm not really sure. I think it's all. That's all I have. Ayub, if there was opening a bags, What should we do for treatment a lesion treated by MTA? Yeah, Ayub, thank you for your question. I think, yeah, with open FX and with the availability of new biomaterials, we have several options because several years ago are not really able to close the FX. We have to do apexification and wait several months to get this calcified barrier, to be able to lab, because after MTI, biodentin, etc., we can close the effects. But what I have showed regarding the bleeding technique, it's an option, if you have an abscess, you can make a bleeding technique, or you can use PRF, or I'm conducting a thesis regarding regeneration in endodontics with one of my students. She's doing a great work, Isra Bournib. Hello, Isra. It's a systematic review regarding the use of regenerative endodontics and this analysis of the international literature. So I think that's it. Thank you all for your questions. Carol,
Hello,
I think
Dr. Latifa.
yeah, I think I will choose right now Bashar. Sorry for the pronunciation. Bashar Sukar Sisa.
No problem. You can make the
Okay.
decision after the webinar and send
No,
to me.
I think it's okay because Bashar really posted a lot of
Okay.
questions.
Who you will choose for the best question?
The right Bashar. Sorry, I think there
Also,
are.
you need to write to us. Even
Yeah,
you say,
there are two Bashar. Hello, Bashar. There are two Bashar, and I'm sorry, I think the one who posted several questions is Bashar Maqdid Sisa. That's it.
okay. Yes. Okay, no problem. You also say
Yeah,
uh,
I
write
will
to us.
communicate. I don't wanna give you right now the
And,
answer. I
and,
will
and we
communicate.
and we
Um,
yes, also we will talk on the common.
okay. Yeah.
Thank you so much for your such wonderful lecture. A lot of dentist very like your
Thank you, Carol. Thank you.
lecture.
Yeah. Thank you. Thank you very much.
Thanks for your
Thank
time,
you all.
and I
Bye
hope
bye.
to see you in next time. Bye bye.
Yeah. Bye bye. Thank you very
Bye
much.
bye.
Bye bye.
Okay. Now we will pick up one lucky person who leave their comment in our page. 1, 2, 3, star. The winner is Hematic Hematic Tenku. We will connect you to support COXO Hempis. COXO is continue made the fees free public webinar. So please follow to our page and you can win COXO gift. Thanks for all the dentists from all over the world. Thank you and see you next week. Bye bye.